Okay, thank you, Chairman. I'm so much grateful for having me here, and I'm so much excited to talk about my favorite topic in front of all these titans of this field. And my assignment today is to talk about if liver transplant can cure neuroendocrine liver mets, and I have no disclosures. So I'm here to discuss if the current position of liver transplant for neuroendocrine liver mets, and in the context of a transplant oncology, just that Patricia had mentioned. And so my presentation today will follow this order. And let me start with how far have we come. So this is the most recent review article that was published just last year. It looked at over 1,100 patients. Out of 1,200 papers eligible, they studied 64 papers, and the outcomes were the 5-year survival at overall survival was a little over 60%, with the recurrence rate, the highest was as high as 57%. The poor prognostic factors, we know this from previous reports, but if the patient has a large tumor burden or high Ki-67 index or pancreatic neuroendocrine tumors, these were the patients that will do bad compared to other patients. So let me just quickly review important papers that were also selected in this meta-analysis. One is from the ELTR registry that looked at 213 patients in 35 European centers that were transplanted during 1980s to 2009. So what they found was that significantly improved overall survival at 5 years after year 2000 due to more strict patient selection. So basically, they had less major procedures in addition to liver transplant, and less patients with poorly differentiated tumors were eligible to liver transplant, and less hepatomegaly. This is I keep on saying this, but the patients with large tumor burden, they don't do well. So they found this independent poor prognostic factors after year 2000. Three factors were responsible for poor prognosis, including age over 45, and combined resection together with liver transplant, and again, hepatomegaly. So they were able to stratify patients according to the number of risk factors. And then this paper is from the UNOS registry that looked at 85 liver transplants done from 1998 to 2012. And what they found was that the combination of large vessel invasion, the presence of large vessel invasion, together with the type of resection that was done together with liver transplant, those were the prognostic factors, and they labeled each patient from score of 0 to 2, and they were also again able to stratify the patients that were significantly differed in terms of overall survival. So after all these exhaustive attempts of liver transplant for unresectable neuroendocrine liver mets, Dr. Mazzaferro actually changed the concept of why we do this liver transplant for these patients. Instead of just for a rescue for those patients as the last resort for unresectable neuroendocrine liver metastasis, he tried to find out the patients who really can be cured by liver transplant. So he came up with an inclusion criteria, very strict criteria that includes both anatomical and imaging factors taken into consideration. That means basically we're dealing with tumor biology, which is always the most important factor when we think about surgical oncology, as well as the duration of response to therapies. So this is the Milan criteria for neuroendocrine liver mets. So this was proposed in year 2007, and then thereafter, Dr. Mazzaferro and his team has then prospective study. And this is the study that was published 2 years ago. This is a landmark paper in regards to liver transplant for unresectable neuroendocrine liver mets. So out of 280 patients who were referred for liver transplant to their centers, they made 2 rounds of exclusion in terms of disease progression and also eligibility for liver transplant. And finally, they were able to select 42 patients who received liver transplant. And out of these 42 patients, pancreatic neuroendocrine tumors consisted of 1/3 of the patients, and hepatic involvement less than 50% were over 90%, and most of them were well-differentiated neuroendocrine tumors. And then they were compared with 46 patients who were not able to go to liver transplant due to either patient refusal or the availability of the liver transplant wait list. The outcomes were amazing. The transplant group enjoyed a 5-year survival of over 97%, and at 10 years, the overall survival was still close to 90%. Compared to the non-transplant group, the 5-year survival at 5-year survival was only 50%, and at 10 years was 22%. And also, the time to progression there was a considerable difference between the 2 groups. In the transplant group, the time to progression at 5 years was only 13%. So clearly, to answer the question of if liver transplant can cure unresectable neuroendocrine liver mets, the answer is yes in highly selected patients. And this is the only prospective trial so far that we know for liver transplant for neuroendocrine liver mets. And then, as Dr. Rosen keep on asking us, where's the survival benefit of liver transplant over other treatment modalities? And Dr. Mazzaferro answered to this a very important question by using statistical analysis, and they found that the transplant benefit actually increases over time, and at 10 years, the transplant benefit is over 3 years compared to non-transplant group. So apparently, liver transplant has the potential to cure unresectable neuroendocrine liver mets. But the question is if this outcome is reproducible throughout the world. So we know that Dr. Mazzaferro and his group was very successful in using liver transplant for unresectable neuroendocrine liver mets, but how are other selection criteria doing? So I just presented Dr. Mazzaferro's Milan criteria, and the UNOS OPTN has adopted this the idea of Milan criteria at year 2015, and they released the UNOS released the guidelines for to select patients for neuroendocrine tumors. I just presented this short version over here. Basically, it follows all the essentials of Milan criteria. The only difference is that they don't mention anything about chemotherapy, the response to chemotherapy. And then there's an important notion saying that this inclusion criteria can be expanded as each UNOS region accumulates experience in transplanting these neuroendocrine liver mets, which is a little bit concerning. We always worry about futile transplants, and this concern was real. In a publication that came up last year, actually 2 years ago, they found that about 50% of liver transplant candidates with unresectable neuroendocrine liver mets, about half of them receive MELD exception points with wide variability. But whether or not they receive any kinds of MELD exceptions, the overall survival after liver transplant was a little over 60%, statistically significantly lower than other conventional indications for liver transplant. And actually, the MELD exception point itself did not was not a predictor of survival, but but they found that bilirubin level was more predictive of survival. So basically, we have to select patients who would really benefit from liver transplant if we're transplanting for unresectable neuroendocrine liver mets. Then this afternoon we heard an outstanding presentation by Dr. Filling from UK, and she categorized liver metastasis into 3 types. And basically, what she proposed that liver transplantation can be worthwhile in certain patients in type 2 and type 3 tumors. She also made very important, insightful notions that saying that downstaging while on the waiting list should become part of the transplant protocol. And the other notion was that liver transplant should not be offered as an ultima ratio solution, but instead it should be done in a timely fashion, meaning that the disease should be still within in a controllable stage. And then the ENES consensus guidelines that was released 2 years ago, it doesn't say much about liver transplant. Basically, they say that liver transplant is generally not recommended. It may be only an option in highly selected patients, maybe less than 1% of all patients with liver metastasis. And again, precise selection of patients may improve survival rates. We all know this. And what the NCCN guidelines say, this is the newest version that came up this May. It is even more pessimistic, and they say that based on the meta-analysis that were published in 2014, that the majority of patients undergoing liver transplant will ultimately develop recurrence. So basically, liver transplant should not be done outside clinical trial setting. This holds true both for pancreatic neuroendocrine tumors and also GI neuroendocrine tumors as well. So, like I said, liver transplant may cure unresectable neuroendocrine liver mets, but there are so many unanswered questions actually. So this is the list of unanswered questions that we have to tackle one by each. And one very important point, actually a major concern, is that even though Dr. Mazzaferro and his team has done a great job in treating patients with liver transplant, when you remember, all the patients were recruited during a 15-year period from 1995 to 2010, which was before all these new molecular target agents and other treatment modalities such as PRRT. So this is a slide I borrowed from Dr. Kudo in Japan. He's probably one of he's a surgeon who's taking care of the biggest number of patients with neuroendocrine tumors in Japan. And he clearly visualized the emerging therapies that came after 2010, including everolimus and sunitinib, and as well as lanreotide. And again, I'm showing this NCCN guidelines. In the red box, lanreotide, everolimus, sunitinib, PRRT. These are the treatment modalities that significantly change patients' disease recurrence rates and all that. And when you look back at Dr. Mazzaferro's paper, it says that in the non-transplant cohort, only a very limited number of patients actually receive these newer agents, including sunitinib, everolimus, and PRRT. So when all these are taken into consideration, we're not quite sure if this survival benefit is as in the paper, the survival benefit exceeds 3 years at the 10 years mark, but it may not hold true in year 2018. So this is one major concern. And the transplant benefit, this is very important, and Professor Fan from Hong Kong has mentioned about this in his review as well. And then, again, one of the most important thing when you always think about liver transplant for malignancies, resectability. This is the most important and debatable issue that we always have to keep in mind. We already had ALPS expert consensus yesterday, And there was also a beautiful presentation by Dr. Petrowski this afternoon. So I won't touch about portal vein embolization versus ALPS. But indications for extreme resections, this is again something different in term among centers. So let me share my limited experience in extreme resection for this 36-year-old man. So basically what he had was very small liver mets in segment 7 and segment 8. So these are apparently resectable lesions. But when you look at the portal face, the story becomes different. So there, unfortunately, this young gentleman had a portal vein thrombosis at 2 areas. And one was in the SMV, and the other one was in the main portal trunk. So we had an extensive discussion of what to do with this patient, and we decided to go for it. And what we did was that this was the preoperative simulation film by combining this 3D image together with the CAT scan. So this green area indicates the point of portal vein tumor thrombosis. So what we did was that we used this portal systemic bypass and to remove the tumor thrombosis together with the portal vein, and we replaced the portal vein using the femoral venous graft. So this is how it looked like at the time of the operation. And this is the resected specimen. So this is still doable, but I'm not quite sure if this is something that we should recommend all the surgeons to do this type of extreme resections. So when you think about all these new drugs, new treatment modalities, and also resectability versus transplantability, it's all over. So there's an urgent need for a common language to treat the patients in their desperate need. So that brings us to the last component of my presentation today, fusion of transplantation medicine and oncology. So traditionally, when we look at this tumors that may potentially be resectable or transplantable, basically there are two different sets of team that tackle this problem. One is surgical oncology, which has more than 200 years of history, and versus transplant surgery, which is a little over 50 years of history. And when we look at this liver metastasis, basically the surgical oncology team think about whether we should attack this patient with either open or lap liver resection, portal vein embolization versus ALPS, maybe radiofrequency ablation, and also extreme liver resection, including ex vivo resection or anticytoma resection. And then there's transplant surgery that think that we can treat and cure the patient with liver transplant for unresectable lesions. The way I see it is that this hepatobiliary malignancies should become a full spectrum by integrating oncology and transplantation medicine. So this is why we came up with the concept of transplant oncology. This is so liver transplant for metastatic liver tumors that I just mentioned to you is only a small part of transplant oncology. It's a whole wide, broad range of how to deal with cancer patients and application of transplant techniques to extend the limits of cancer surgery. And probably the biggest part would be tumor and transplant immunology, which includes cancer immunogenomics. So thanks to Patricia, we're now we came up with a special interest group for transplant oncology in this May in Lisbon, and we're going to have a consensus conference specifically for transplant oncology to be held in Rotterdam next February. So in conclusion, the future of transplant oncology that I envision is in this painting. Thank you so much for your kind attention, and I'm happy to take questions.
Thank you very much. I think we have time for one question, if there is any questions from the floor. If not, okay, thank you very much. Taizo, I think we can go on with the last presentation.